Senanga, thumbs up if you can hear us. Senanga, please, may we have a thumbs up if you can hear us? Can Senanga hear us? Yeah. Okay, we'll move on to Choma. Can somebody please introduce the team and the province? Choma General Hospital, can you hear us? Can somebody introduce the team and the province, please? Okay, I'm trying. Livingstone General Hospital, can you hear us? Livingstone, can you hear us? It's a sound issue. Yeah, we'll try. Dr. Mlenga, I planned to introduce you last, but we seem to be having some sound issues. Please introduce yourself and can you hear us? I see you can hear us. That's good. Please introduce yourself.
I can hear you very well. I'm Lloyd Mlenga. I'm joining in from the US, from Baltimore.
Oh, wow. What time is it in Baltimore?
It's 8:30.
Okay, so it didn't wake you up. So we're going to try again, just to make sure people can hear us. From our spokes, Lewanika, Senanga, Livingstone, if you can hear us, may we just get a thumbs up? I don't think we'll be able to introduce the teams again. Okay. Oh. Okay, Choma, would you like to introduce yourselves? Dr. Mpeta, you're welcome. Okay, it seems people can hear us, but when we try to reach out, we can't hear them. However, I'll go ahead and introduce the hub. Oh, I see Chipata has joined us. Chipata, you're welcome.
Thank you so much.
Okay. Are you able to introduce yourself and your team?
Okay, this is Prince Munyati and my colleague, his name is Monga. We're just about to be joined by the clinicians. They're just about to regroup. They let meeting over lunch, so they'll regroup in the next few minutes.
Okay, thank you so much for joining us. I'll go ahead and introduce the team in the hub. So we have a very big team. I'm joined by people from pharmacy, from IT, from data. We're also joined by a team from CDC. We have people from the Adult Center of Excellence, the Pediatric Center of Excellence. We have our HIV clinical mentors, and we are also joined by the MMed ID team who are here to give their expertise. And this is Sombo. So Dr. Mlenga, are you able to share your screen and start your presentation? But we'll start with a polling question, then you can share your screen.
Okay.
So people can take a few minutes to look at those and answer those. Petaoke, you're welcome.
Thank you so much.
You need to scroll down because there are actually two polling questions.
The very first question, eh? When it's true, but they are multiple choice.
So we're getting some sound from our spokesman. May we all please mute ourselves? Jenna, can you hear us, Jenna?
Yes, I can hear you guys. Can you hear me?
Yes, we can hear you. You're welcome.
Thank you very much.
HW21, please go ahead with your question.
Good afternoon, everyone. Dr. Sombo, I'm Dr. Ali Pali from here, UTH. Will be presenting the case.
Not ready yet.
So I thought of introducing.
Okay, thank you very much, Dr. Ali. In short, he's saying we forgot him. Sorry we forgot you because we had so much bad sound. Thank you for that, Dr. Ali. Sorry, Dr. Mlenga, are you able to share your screen?
Sure.
Okay, you can go ahead with your didactic presentation.
I don't know if you're able to see it.
No, No, we can't see it. Are you able to try again? If you fail, we can put up your slides from here.
Are you able to see it?
No, we can't see your screen. Have you shared it?
Yes.
Okay. So we are going to upload from the hub.
Yes.
Okay. Is that as well? Okay, that's our slides. So you can go ahead with your presentation. We'll put it in slide mode just now.
Let me know when you are ready.
I think you can go ahead with the preamble. We are just trying to put it in slide view. We are very ready now.
So just giving an overview of the coverage for ART and certain things that we need to look out for as we move on. We all know the prevalence is 12%, and the provinces represented here, Southern with 13.3% and also Western 15.9%, Lusaka 15.7%, then Eastern 8.1%. If you go to slide 2, Western province, the ART coverage is 52%. And you can see various districts, Senanga is around 56%. You can look at Mongu, it's at 76%. So you can go through and see where we are. With the, of course, we have very low numbers like Mitete with 25% coverage and Luampa also 25% coverage. Lusaka is higher, and this, of course, has gone up for Lusaka to about 85% coverage. With Chilanga, of course, needs to pick up 58% coverage, and we have areas like Chirundu, which are doing pretty well, mostly because of people moving in. For Eastern Province, as well, you can see almost close to 80% coverage. I think the number may have to be adjusted when we receive the latest information. But again, there are areas like Vubwi, where you can see that we need to put more people on treatment. Even Petauke, which has joined in, we need to put more people on treatment for us to be close to the ideal for the coverage and if we are going to achieve the epidemic control. Southern Province, the numbers are generally low than what is expected with 69% ART coverage. So we have a lot of work to do. If you look again in the districts, 52% for Mazabuka, which should be higher, Livingstone 50%, and also Zimba 50%. Suppression again across the 4 provinces is also low. And this is where we are as a country for the clinical cascade for the 1990, 72%, then 91.4% for those that are on treatment, then 86.2% for virologic suppression. Now, this is not encouraging in that we are looking at the picture, so there are certain areas where we need to concentrate on, and as we move on as a program, we need to looking at granular data and granular analysis of what is happening in almost all the districts on each facility. Again, this is an old slide. This is of 2017. It highlights the coverage again by district. You see there are certain districts where if the paper ones, the coverage is above 80%, but majority the coverage is below. So this shows that we need to do a lot more. Then there is a trial, a randomized trial from Lesotho, because the Cascade trial, looking at same-day ART insertion. Same-day ART insertion is key for us to be able to put more people on treatment. Now, a lot of people have questioned if same-day ART is really effective in terms of loss to follow-up and also virologic suppression. If you look at this slide, in terms of retention, say those patients who are initiated on same-day ART, they have better retention than those who have usual care. And in this cascade trial, it's a community-based. Those that are tested at the community, they were given ART at community level. Then another group, they were given ART using the normal referral system, which we do mostly in our countries. So when you look at how many were retained into care, 6 months, a year, we found that there was those patients that were on same-day ART initiation had better retention compared to those who did not go on to same-day ART initiation. Again, the next slide is looking at virologic suppression. Again, that's another thing where we fear that possibly the people that are started on same-day ART may have poor adherence and suppression may be low. We find that even suppression was better for those that started same-day ART compared to the usual. So again, just these two slides, I wanted to highlight the fact that we don't need to wait so much for us not to initiate the patients who are supposed to be on ART. This slide is from the guidelines. How do we initiate the people on treatment? The only worry which we have are kidney dysfunction. So we need to just look for risk factors for kidney dysfunction, and those risk factors are highlighted there. And these tables, this should be table 6 in the 2018 consolidated guidelines. We need to refer to it more often. If someone has no risk factor for kidney disease, and then we need to start them on the TDF. Then in the coming, likely in the coming 3 weeks to a month or so, we should be receiving also TAF as well. So for those where we have, we think that there's no renal insufficiency with the creatinine clearance more than 30, we can initiate them on TAF. Otherwise, we have to initiate on a Abacava-based regimen. So there is no way in this where we say we don't have to initiate people on treatment, except in certain cases where someone may have TB or they may have CNS infection, where you need to wait until you treat those or evaluate further before you put someone on treatment. And again, the drug of choice is DTG-based. Then those that are not on DTG-based, the efavirenz-based regime, the 400 milligrams of efavirenz. Again, if I'm doing the slides, I'll be emphasizing on what our priorities are. It's universal coverage, ART saturation, and we cannot achieve ART saturation if we are not going to have same-day ART. Elimination of HIV and also syphilis in the pregnant women. Then also we need to look at introduction of other safer regimens, the DTG, then 400 milligrams for those that cannot be on DTG, TAF, and also emphasize on the prevention models. DSDs, management of supplies is very key, drug resistance surveillance, and again, these are major key recommendations which we all need to be aware of, and also they answer to the key, they are all leading to us achieving the second 90, the first 90, and also the third 90, self-testing, universal coverage, PrEP, and also initiation, then introduction of those better and safer drugs. Thank you, Dr. Foloshi.
Thank you so much, Dr. Mlenga. You were very clear. I'm so sorry that you couldn't share your screen. We are going to share the polling question again before we move on to Dr. Ali, who has a case that you will help us sort out as our content expert. But the good news is that your MAT students are here, so I'm sure they'll also input into the case.
Hello, Dr.
So the polling question is up. We need to answer the question after the didactic presentation. Okay, we can see some responses. Okay, thank you very much. I can see we are getting a lot of responses, some improvement there. So we're going to move on and have Dr. Ali, who's joining us from one of our spokes, which is HW21. Dr. Ali, are you ready with your case presentation?
Yes, Dr. Sombo. Good afternoon, everyone, participants.
Good afternoon. Okay, we can see your screen very well. You can go ahead when you are ready.
Okay, please, would you like to remove the question there?
Sorry, Dr. Ali, say that again.
There's a block in front of the, how to remove it?
Slide mode.
Dr. Ali, may you and the team put your presentation in slide mode?
Okay.
Oh, well done. Perfect.
Okay. How to go to the next slide? Okay. So let me start the presentation. He's a 50-year-old male, and he presented 2 weeks ago at our center. He's married with 2 kids, and the youngest is 12 years old. The presenting chief complaint was painful swallowing. So what we call dysphagia, and a sore throat for more than a month. And then he also noted some ulcers in the oral cavity. So before he came, he presented at a private hospital, and he declined to do the test for HIV. And he was given some medications there, and then he came to UTH, where he was started being taken care of. He did the test, was positive for HIV. And then on presentation, there were no other complaints: no fever, no cough, no night sweats, no weight loss. And on the first episode, that was his complaint, that he had only oral ulcers and unable to swallow, dysphagia. And no other ulcers, no genital ulcers, and any other history of TB or STI, asthma or hypertension or diabetes in the past. So he came with his wife, and he was also tested positive. And she was stable in condition and was waiting to start CRT. So on general examination, his pulse was 117, the BP was 120/87, the temperature was 37.4, the chest was clear, abdomen was soft. And then on the oral examination, he had 3 centimeter ulcer on the right side of the soft palate, and a 1 centimeter ulcer on the left side. So it was very congested, the ulcers, and he had difficulty in speaking. So he was in pain at the time of examination 2 weeks ago. So on other investigations, which we requested, the X-ray was normal, and then the ultrasound for the abdomen was normal. We requested for labs. So that's a slide showing the ulcer in the oral cavity. So this picture was taken today. So the previous picture, which we took 2 weeks ago, was quite congested and discharging pus. Can I move to the next slide?
Yes, Dr. Ali.
Okay. And then these are the baseline investigations we did for him. The baseline CD4 is 52. RPR, hepatitis B is non-reactive. His creatinine was 105. And based on his weight, the GFR was 77. His HB was 9.2. And WBC count was 6.5 times 10 to the power of 9. The platelets were in the normal range, and ALT and AST were in the normal range. So the treatment prior to coming to UTH, this was at the private hospital. He received miconazole, that is oral gel, and iron syrup, and dress, gargle, and these are all actually some of the gels for gargle. He was using these gargles 3 times a day, and also he received an antibiotic, cefuroxime. So he was still in pain, and he was still discharging from the ulcers when we saw him at UTH. So our prescriptions were, we prescribed him acyclovir 400 milligrams 3 times daily for 10 days, and cefixime. That's also for 10 days, and some analgesics. So after 2 weeks, he came back, and he's able to swallow now. However, he complained of slight pain. Like he said today, it was much better. He didn't use any painkiller. That was in the morning. And as we saw today, it was showing some slight redness, no discharge, and is able to swallow, and some weight gain. So that's the case slides. We are moving into the question now. Since it's 2 weeks now from the start, we gave him the antibiotics. What is the right time for us to initiate ART? Thank you very much.
Thank you very much, Dr. Ali. So we are now going to move to our spokes. Are there any clarifications from the spokes? Any questions for Dr. Ali? Any points that he needs to clarify on this case that is presented? Sorry, we can't hear you. Just move a bit closer to the mic. Please go ahead with your question.
Are you talking to us, Senanga?
Yes, Senanga, please go ahead with your question. We can hear you very well. I can see Yuta has joined us. Hi, Yuta, you're welcome. Senanga, I propose that you turn off your video facility so that you just focus on your sound. Maybe we'll be able to get your question because we cannot hear it at this point. Just switch off your video. While Senanga is preparing, okay. Senanga, please go ahead with your question. Any other spokes with any questions? Okay, so we are going to move on to the hub. Are there any questions for Dr. Ali from us in the hub? I have a question, Dr. Ali. What other things was this gentleman given before your acyclovir and cefuroxime?
So prior to coming to UTS, Dr. Sombo, he received cefuroxime antibiotic at one of the private clinics, Arbitone, miconazole gel, oral gel, Quadrigel, and some painkillers.
Okay, that's a lot of trade name. I know that I looked up Adolin, and it's something that's supposed to improve appetite, and food is a supplement. So there's a question here. Please go ahead.
Good afternoon, I'm Dr. Mutuma. I'd like to find out, with oral ulcer and the discharge, was there any other STI screening that was done besides pus swab or biopsy done?
So the question, Dr. Ali, was there any STI screening done based on the lesions that you found in the mouth?
So we did the syphilis test, and apart from that, we didn't do anything. And we collected the blood samples. For the pus swab, we didn't collect the pus swab at the initial visit.
Okay.
So based on the pain and based on looking at the ulcers, the size, we thought of first giving the treatment for herpetic ulcers.
So you have another question from the hub? Ahmed, go ahead.
Yeah, thanks for the case. I've seen the CD4 count is less than 100, and this is a new patient. I was going to ask, did you perform any cryptococcal antigen screening for these patients?
Did you get the question, Dr. Ali?
Yes, thank you very much for the question. Since he didn't complain of any symptoms of headache, but we didn't do the crack test.
Okay, so the crack wasn't done.
Yeah, based on the symptoms, we went for only the herpetic ulcer treatment.
Okay, thank you very much, Dr. Ali. So he says they didn't because he was asymptomatic. Dr. Mlenga, please go ahead with your comment or your question.
Did you go into the sexual history for this patient? Any oral intercourse or any sex with men, or just assume that because he's married?
Thank you, Dr. Lloyd. I asked him on those. He said he's married, and then he didn't have any other partner, and he rarely uses condoms.
And what's no male partner involved?
Dr. Ali?
No partner.
Okay, good. He can.
Yeah, no, he never had any other partner.
Any more questions from the hub?
What is the Chiku and Lola? You're on the phone.
Sorry, could that facility that's speaking identify themselves, the person who's talking, and the facility then will take your question? Okay, while we're trying to sort that out, I see some people have just joined us. In summary, we are discussing Dr. Lipali's patient, who was an intraclinic referral, 50-year-old male, essentially newly diagnosed HIV, who presents with painful oral ulcers, seems to have some slight improvement of symptoms after acyclovir. The decision that was made by the attending clinician was to send the patient home to come back after 2 weeks to initiate ART. So we are now in the question and answer session. If you have a question for Dr. Ali, please go ahead. Dr. Ahmed, please go ahead with your question.
I just wanted to follow up on the crypto antigen question. So I guess my understanding was, what I know is that a new patient, even asymptomatic, needs to be screened for the blood crypto antigen if they have less than 100 CD4. But if they are symptomatic, you need to go for a lumbar puncture.
Okay, did we hear that? Are there any comments from people in the hub? Is that what the Zambian guidelines say? Dr. Tilele, would you like to address that, please?
Okay. Well, so typically, according to the guidelines that we have now, we don't routinely do serum CRAG in patients with a CD4 less than 100. Yes, it can be indicated, but due to the cost of the test, so we don't routinely do the serum CRAG. So we reserve it with patients who are symptomatic or who we suspect could have underlying cryptococcal disease.
Okay, so thanks for the answer. The idea of screening while patient is still asymptomatic is to make sure he doesn't develop an iris when he starts ARVs. Because if he starts ARVs, the likelihood that these patients will die is very high. So in terms of cost effectiveness, it makes more sense to screen people who have less than 100 CD4 before they start ARVs, even if they are, especially if they are asymptomatic. Because if they are symptomatic, you have to go for lumbar puncture, not even a serum CRAG. I know it's not in the guidelines, and that's why I asked the question. You might be losing a number of patients due to iris after starting ARVs as a result of not screening new patients with less than 100 CD4 early enough. So that's my point.
Thank you very much, Ahmed. Dr. Ahmed is trying to talk about issues of doing a crypto antigen test in people with a CD4 less than 100. However, it does not state so in the Zambian guidelines. I don't know if Dr. Duncan would like to add on to these observations.
Yeah, so previously we did a clinical trial which included the screening for serum CRAG in people with advanced AIDS, and they were also initiating them on ART like within 48 hours, followed by community adherence. In that trial, we showed that a combination of CRAG screening, accelerated initiation of ART, and the adherence for 4 weeks were able to reduce mortality by 28%. It's something I presented to. We presented to various fora, and I think some countries, one of the sites was in Tanzania. I think Tanzania has adopted that, or at least are trying to implement that. We haven't done that here, but having said that, I think most clinicians also realize we get a lot of patients who would develop cryptococcal meningitis in the first 1 to 2 months when they've just initiated ART. So I think CRAG screening is something we have to think about. In that trial, the patients who are positive actually were delayed to initiate ART. We delayed by up to 4 weeks. And we assumed some of the good results we saw is because we picked out these patients who are going to develop crypto meningitis. Yeah.
Sorry, Dr. Chanda, you brought up something interesting. In the era of test and start, why did you delay these patients who are the positive CRAG on ART initiation?
It's because basically it has been shown previously patients with crypto antigen positivity are likely to develop meningitis within, I think, a median time of about 4 weeks or somewhere there. And so if you initiated the ART immediately, you'll be initiating ART and the maybe anti-cryptococcal treatment at the same time. And the outcomes in this group of patients are worse off than if you delayed initiating ART 2 weeks. Yeah.
Okay, so that's one of the diseases where you want to delay before you initiate ART because mortality is increased. I'm aware that there's some data that you need before you can say a country can do baseline CRAG at initiation. I don't know, Dr. Mlenga, if you'd want to speak to this. I know we don't have this data.
We've gone so much into crypto and not concentrating on the client we have. But yes, as everyone has said, we don't routinely test for crypto in our area. I think in the next 3 months or so, we are going to assess the antigenemia for crypto. We are using the Zambia specimens, and we are going to have a burden also known. Then from there, we are going to make recommendations. We know CDC does recommend, the WHO recommendations. There are countries that have recommended, but as a country, we have not moved that way. But we realize that it's important, but we need to have baseline data because it's very costly as well once we move into this.
Okay, so it's because we do not have the background cryptococcal antigenemia in our population. That may be one of the factors that has hindered this. I see, Leonard, you've got a question. Please go ahead.
Yes, Sombo. It's actually not a question. It's more of a comment that I was just writing on the chat box there, highlighting especially the challenges in seeing the symptoms of, let's say, cryptococcal meningitis, especially with people who have severe immunosuppression, like this patient who has been presented with a CD4 count of 53. Very hard to, at times, actually clearly see the symptoms and the signs of cryptococcal meningitis. Hence, the recommendation, or more people favoring doing a routine serum Craig. However, I understand as well what Lloyd just mentioned, especially in terms of cost. You need to always balance the cost effectiveness. Serum Craig is not a cheap test to do. Here in Namibia, we do it with a CD4 count of less than 200. But it was because of some data that we had showing really that the mortality was going to improve, and it was going to be cost effective to do so. But so I think it's too important to analyze your own data and see how you can then use it to streamline your own guidelines. Thank you.
Thank you very much, Leonard, for that. So it's something that's a worthwhile thing about. Dr. Mary Boyd, please go ahead.
So I'm moving away from Craig for a minute. So the presenter, Dr. Alpali, you said that there was a decision to delay treatment for 2 weeks. So I'm just trying to understand what were the reasons behind wanting to delay it? Was it that you advised the patient to start, but they said not now, or did you make a decision as the clinician to not start for other reasons? And if you can share those with us.
Thank you. That's from CTC. Thank you, madam. The delay was because this is an opportunistic infection. So I would like to try the infection first, and then if the ulcers, actually from the pictures we saw today, they are healing. And then my question is like, should we still wait to start ARVs? Or should we continue the treatment for acyclovir for some more time? So that's my question.
Would somebody from one of our spokes like to comment on that delay of ART initiate? Livingston, please go ahead with your comment. Or your question. Dr. Mtengo, I can see you. Go ahead. Sorry, Dr. Mtengo, we actually cannot hear you, but you can actually use the chat box and type in your comment or your question. I think we'll just have a look and we'll read it out after that. So Dr. Alipali did not initiate ART because he believes that's an OI. He thought this is herpes because he used acyclovir. Are there any comments from the hub on this delayed initiation of ART? I know Dr. Duncan has said we should delay in crypto. Are there any other conditions where I would like to delay ART initiation?
TB.
So one has come up as TB. So the question is, should we delay ART initiation in people who have herpes? Because he was worried about iris. What's the comment from the hub? Dr. Zico, would you like to comment on this?
The hub is muted right now.
That's me. Sorry, Yuta. Go ahead.
Okay. So the patient was unable to swallow because of the suspected herpes, which affected his ability to swallow. So I think the patient could have been delayed, and now that the patient is able to swallow, I don't think there is any reason for any further delay. So I think the patient can commence ART as soon as possible.
Thank you very much, Dr. Ziko. Before I comment on that, would you like to read out what Dr. Mtengo has sent in?
Okay. From the one, first we have the question from the Wanika. Why is the patient not on Septrin?
So there's a question, why is the patient not on Septrin, Dr. Ali?
So yeah, we received some of his labs a bit late, so we actually started his Septrin today. So there was a delay in getting some of the results like RPR, hepatitis. At the initial stage, the first visit, yeah, we had only a few investigations.
Okay, so we've started the Septrin today, not the ART?
Not the ART.
Okay, any comment on that from people in the hub? Dr. Mlenga, please go ahead and comment on that line of management.
I would suggest that any future patients where we have clinical symptoms, we start with the Septrin as well, as has been indicated. We don't have to wait for the other lab tests for us to initiate the Septrin. Then this patient, I don't think the patient really has an OI which you are worried of iris, such that if you started on treatment, you think that they may have iris. As you know, there are a lot of causes of oral ulcers. I think the ID team, that's another topic which can be discussed later. I think in your analysis, you are mostly looking at herpes, but there are things like varicella as well, there's CMV as well. There are even other non-infectious causes, non-viral bacteria as well. There are even HIV as well, not directly related. You have those recurrent aphthous ulcers. So you were treating just one aspect. And I don't think that the herpes simplex would have really been an issue for you not to initiate therapy. What could, I think, in my opinion, could have helped also in your assessment for when to initiate therapies is the patient able to swallow. And there are certain things which you may have to consider. This is severely immunosuppressed patient. I don't think we need to wait any longer. Can they even crush tablets? Are there pharmacists on board? Maybe the pharmacists can advise. Because you can even go that way. If they can crush, we're now talking of one tablet once a day. It's easier to crush that tablet. And the patient can easily take the drugs.
Okay, so that's a very good observation. Can our pharmacists help us? Because this patient is 50 years old. He's a candidate for TLD. Is TLD crushable? I don't. What's the bioavailability, the pharmacokinetics when we crush TLD? From our pharmacist on board? Looking that up. Livingston, please go ahead. I hope we can hear you this time.
Okay, so the question from Livingston Central. Is there any reason why cultured moxazole prophylaxis was not initiated while waiting for to start ART?
Okay, I think that question has been answered already. Cotrimoxazole is Septrin. So he actually started the ART, the Septrin today. However, I've got a question for the spokes out there and us in the hub. Really, is Septrin an emergency in this patient? What did this patient need more, the TLD or the Septrin?
I think Zico was trying to say probably the patient could not swallow. That is not clear. What I would suggest is we could also prescribe a painkiller to help the patient swallow. I think this patient needed the TLD immediately, even the Bactrim anyway. So I think to delay in these circumstances, I think wouldn't have been the best of the options available.
Okay. Ahmed, please go ahead. You need to speak up.
There is another prophylaxis that was not prescribed. I'm not sure if you can guess which one it is.
I'm sure he's asking people here. Dr. Ahmed is asking what
patient has less than 100 CD4, and it's in the guidelines.
I'm very happy that Dr. Zico, you are the one who's answered that, because you talked about the swallowing. So it takes me back to the first question of what are our priorities in this patient who cannot swallow? To prescribe TLD with INH and Septrin, or do it one at a time until a time when he can swallow 3 tablets?
There is another one.
Yes.
Fluconazole was not prescribed. If you don't do screening, at least give fluconazole, which is already a prophylaxis also. There is something to be done about cryptoprophylaxis here. And just to follow up on what was said about crypto prevalence here, antigen, the prevalence here should not be very much different from neighboring countries where it's at least 5%, 10%. And the studies have shown that for prevalence that's higher than 0.5%, it's already cost effective to do the CRAG.
Okay, thank you very much, Dr. Ahmed.
Just an observation that probably swallowing may not have been a big issue because it was on a cycle, right? I mean, that was something
Yes, so I think from what Dr. Ali presented, the patient who had issues to the point of losing weight for a month. He only started swallowing liquids now. I suspect he was crushing them, as Dr. Zico was saying. And I think it takes us back. What did he need more? The acyclovir, the TLD, or the INH with the Septrin? So I guess you would have to use a lot of clinical reasoning in these patients. But I have another question. Other things that can cause oral ulcers are things like after ulcers and CMV. When we looked at that lesion, it's a solitary, it looks like a solitary lesion, but it's not. They were multiple and they were exquisitely painful. They were very painful. What about CMV, especially in the context of looking at the expense of diagnostics? Anything that maybe we could have done? What about the fundoscopy? What is the commonest presentation of CMV in HIV? The CMV retinitis, isn't it? So fundoscopy is cheap, it's bedside, and we're able to do it. I'll let Dr. Mlenga comment further on this patient before we lose time. We're running out of time. It's a very exciting case.
I think I know I've seen that Dr. Ahmed is very passionate over the crypto. What I wouldn't recommend is that we give guidelines, especially there are people out there who are listening. We give guidelines to this platform. We have a lot of people from out, and whatever we may discuss here, may think that's policy. There are a lot of considerations which we have to make before we move into policy, and all those policy decisions have to go through the technical working group, and they go higher. So it's well noted that we need to have information and also move into how do we manage those patients who may have low CD4. That is over the crypto. Regarding this patient, I think that this patient needed TLD more than even the acyclovir, and more than the Septrin, and more than the fluconazole, and more than the INH. This patient, we needed to boost the immunity. Then, as you have said as well, CMV is likely a cause. We have, I think in the past 1 month or so, I may have seen 2 cases, oral lesions, which when we treated as CMV, they did respond, we don't know. And also we did, of course, some serum tests as well. But of course, fundoscopy would be important. And we need to remember that, in fact, there's a recent article which came out with CMV retinitis. Even in those with CD4 above 200, you may have CMV retinitis. So here where you have a high index of suspicion, that is another cheap test which you can do, an exam which you can do for us to have a clear guide on where we are moving to. I have to leave my suggestion to the team, Dr. Lipali, who are managing this patient. I think we need to bring in this patient soon so that we can initiate therapy if the patient is ready. Then also, I think the other prophylaxis which have been highlighted, see how they can tolerate them more. There was a time when we used to say we don't need to give the Septrin with the ART at the same time. That was because of the drugs which we are using. The rash is common on day 7 for nevirapine to day 11, and that was the same time for duration of the rash for cotrimoxazole. So we are not initiating the two of them at a go, but it's not a contraindication. You can start cotrimoxazole prophylaxis and ART at the same time, especially with the drugs which we have now.
Thank you very much, Dr. Mlenga, for that summary and wrap up. And Dr. Lipali, are the suggestions clear? There's a hand. Dr. Boyd, please go ahead.
Just one more point. It occurred to me as we were talking that because there are a few different differentials that we're working with, if we try to guess and then pick the wrong drug, we may not end up actually treating the patient's ulcers. But the one drug that we will never be wrong on in an HIV patient is actually heart. And that may end up being the way to help that person's immune system recover so they can actually take care of their infection without our acyclovir or valacyclovir, whatever it is that we normally would use to treat the various ulcers. So just for folks out there, when just to say that when you see something like this, the one sure bet you have is starting heart.
So Dr. Mary Boyd, I really like that because you went into our ID minds. I think we have Dr. Zulu here and Dr. Candio. They can tell us how much of a nightmare it is to get to the bottom of an oral ulcer. Dr. Candio, would you like to tell us about your experience and how we would have delayed ART if we started chasing after a diagnosis of oral ulcers?
Thank you very much. Like Dr. Foloshi has said, evaluating a patient with oral ulcers is not easy. The differential diagnosis is wide, and quite a number of the tests may be expensive and the patient will not be able to afford. I mean, we have PCR that we have not mentioned. So I guess at this point we wait for HSE based on the symptomatology and maybe the availability of the drug, like that's what we could treat. So it's still a challenge when it comes to evaluating a patient who has oral ulcers. So like I can echo what Dr. Mary Boyd has said. I think the best routes we can take where we know won't go wrong is initiating ART and reconstituting the immune system of the patient.
Thank you very much, Dr. Candio. I like the word she has used, immune reconstitution, because with CMV, it actually can just go away with immune reconstitution. So can herpes, though it will be recurrent. So I think the take-home message today is that this patient needed TLD. Thank you very much all for joining us. Thank you so much, Dr. Ali, for giving us this case at very short notice. Well done. Thank you very much all for joining us in the hub. Well done. Done to you. Dr. Ali, well done.
Thank you very much, participants, and thank you very much, Dr. Lloyd.
So next week on Monday at 2:30, we are going to talk about the TLD transition, the number of viral loads you need. We have Dr. Albert Mwango joining us to be our contact expert on that.